Thank you, Raja sir, for those kind words, and I would like to thank you for involving me. Thank you, AIOS, for conducting a retina webinar and with an interesting topic called as Oops in Retina. Thank you, Dr. Chaitra, for moderating this event. I'll just share my screen. And, yes. So I'll just move on with the cases. So this was one of the kid with the firecracker injury. You can see a patch graft there. And when I put the trocar, part of the flap opened up. So I had to resuture that flap. And then I had to do a lensectomy. And then inside you can now see the retina having a detachment. And with a small viewing, I had to, try to view it and do a vitrectomy in that small window. And fortunately, I could get a good view. And here I'm just trying to do the PVD and did a fluid exchange. And then settling the retina back, did a fluid air exchange, laser, and then silicone oil was injected in this patient. So coming to the next case, this is one of the first few cases I started operating under Ingenuity, and my colleague Dr. Girdhar has named it as the window of hope. That is a small view. This was a large foreign body. Unfortunately, it hit him. He was a tile cutter and part of the blade went into his eye. And this surgery is very close to my heart, and for one of the first few when I started doing Ingenuity 4 years from now. So here I had to either tilt the eye and then mag it up. So theoretically, they say Ingenuity has a little bit of peripheral viewing, but I'm not sure because I had to do a head-on comparison for this kind of thing. And here the difficulty was identifying the retina because there was also an altered vitreous hemorrhage in this case. And you can see I had to do a retinectomy to settle it down. Incremental retinectomy had to be done. But again, you can see the PFO entering into the subretinal space. So I had to do a little more retinectomy, what Steve Charles describes it as an incremental retinectomy, and the subfoveal blood was removed. And now you can see the retina being settled well, and the laser was being done. And my fellow was telling there is a MAC hole. So I could even use an intraop OCT on this to check it through that small part, and did a fluid air exchange. So here I could view either through the left or through the right and not through the center, because sometimes these hazy view make it more larger on the Ingenuity screen. And coming to the next, this is last but one video of mine. You can see the hazy cornea there. So this was a closed funnel RD of a young boy. So I explained a very guarded visual prognosis to the parents, but parents were very anxious and they wanted me to give a try. And here again, through that small viewing window, I had to tilt the eye and try to do these maneuvers, but I was quite lucky where I could get a good viewing out of that small area. And thanks to these wide angle viewing systems and also the different light profiles we have on these 3D visualization system, where you can select your own color, light profile, color channels to make it a more good visualization. So here I'm trying to remove the subretinal blood clots and the fibrotic bands. And putting under chandelier, I think the 3D visualization on the screen, it looks much more better. And step-by-step PFCL was injected. And again, the temporal traction was relieved by doing retinectomy. And finally, I could see a little bit of traction still persisting in the temporal part. So I had to do a little more retinectomy. And this is the small zone which I was mentioning about. And through this small area, I could just shift around. And in this closed funnel RD, the retina settled well. And the laser was done to the edges. of the retinectomy and fluid air exchange was done. And this is my last case. You can see this is the very bad cornea. He had a foreign body. The initial corneal tear repair was done elsewhere and the patient was referred for the VR surgery. And again, you can see the sutures in between. This is the foreign body, vitreous hemorrhage with retinal detachment. So again, through that small area, I could visualize it, zoom it up or mag it up for the 3D under the 3D visualization. And here I'm doing a small tunnel to remove that foreign body. Used an MVR blade to make an entry and use a magnet forceps. And this was the very irregular shaped foreign body. So I had to do a couple of times to move it and align it. Even in spite of aligning, it was not coming that easily. So I had to put the vectors down and then use a dialer to dial it out. And now you can see this is a very irregular shaped foreign body. So it was tough removing through this tunnel. And now the next challenge is to settle the RD in this bad cornea. So again, I went inside and I could see the breaks because of that foreign body there. Completed the vitrectomy, put the PFCL exchange. And just not that, I could even do an ILM peeling in this compromised or hazy view. And finally, lasering inferiorly. And this was at the end of the surgery where we could see almost up to the mid periphery and the periphery through that small viewing area. And I injected a silicone oil in this case and the patient is doing really well. So this is what I was mentioning about, is a slight increase in the peripheral acuity as described in these 3D visualization system, where we have a slightly higher degree of peripheral acuity viewing. And these are the few of the cases, around 8 to 10 cases I tried to do. And it was pretty much successful in these cases. Thank you very much for the patient listening.
Thanks, Shrinivas. As usual,